Out this afternoon. Welcome to our February Wall Family Speaker Series on health, spirituality, and religion. Before I introduce our fabulous speaker, I just have a couple announcements. So for any of the branch students on the call today, just a reminder that if you were interested in our program's non-clinical elective on medicine and faith and religion and spirituality, we are running it in April of this year. And we have a really great lineup of small group discussions set up with U of M faculty from various departments on such topics as how the Abrahamic religions view the body, to writing as prayer, to think about how to create your own philosophy of medicine. So if you have any questions about the elective, please see me for any questions. Also, we have student fellows in the program, as many of you know, and we are taking applications for our next upcoming academic year student fellows. So if you have any questions and you want to apply for our student fellowship, please see myself or Adam or any one of the current student fellows who'd be happy to answer questions. Next week, so as you know, the program holds these monthly sessions during the academic year, but sometimes we hold evening conversations on some difficult topics. So we are hosting a special evening conversation actually next week, Thursday, March 7th at 7 p.m. Eastern Standard Time by Zoom. It's going to be run by one of our former medical students. You probably remember Dr. Rebecca Rao. So she'll be moderating it. So after she witnessed as a medical student here her first patient death, she started asking herself how physicians contemplate their own proximity to suffering. And this project where she interviewed physicians led to her capstone for Impact Project here. And so she's going to be moderating a panel called Contemplative Conversations, an interview series. And the panel of physicians will include Dr. Stephen Lieber, Dr. Ginny Sheffield, Adam and myself. So please come and join us next Thursday, 7 o'clock by Zoom. Details are in our email. And then additionally, I will be giving a talk at the St. Kateri Institute for Catholic Studies on campus. Many of you are maybe familiar with St. Kateri's Institute. So the Kateri Institute is hosting me next Friday, March the 8th. And the title of my talk will be Health on the Portico of Heaven. Registration is required. Anyone's welcome. Dinner will be provided. So see the Kateri Institute's website for any questions you have about that event. All right, now on to today's session. So we are really excited to be hosting Dr. Quentin Jeunesse. So Quentin is an emergency medicine physician at St. Paul's Hospital in Vancouver, Canada, and the physician ethicist for Providence Healthcare there. He holds a Master of Letters from the University of St. Andrews, and he teaches in academic, clinical, professional, and lay settings on a variety of issues related to bioethics, and his research and writing interests include questions around autonomy, end-of-life care, compassion, human dignity, addiction, and theological anthropology. I've had the pleasure of hearing Quentin speak a couple of times at a bioethics symposium we've been both at in Canada the past couple of years, and I can speak to how thoughtful and engaging he is. We were just talking before you all logged on when the first time I heard Quentin speak, he was speaking barefoot. And I was asking him why that is, and he feels like really grounded when he does that. So I'm not sure if he's barefoot today, but maybe we'll hear about that. And also Quentin is a father of 4 little ones, and he's married, and he's just a wonderful person. So we are just really excited, despite his very busy schedule, that he's made time to come speak with us today. And his topic today is addiction and the human person. Quentin, thanks so much for being here, brother.
Yeah, thank you so much. I just want to thumbs up. You can hear me okay? Okay, amazing.
Yeah, perfect.
Thank you so much for the invitation. I'm just going to share my screen here. All right. Yeah, and I wanted to say, before diving into my talk, just a really big thank you to the program, to Kristen. It made my day when I received the invitation to speak. I'm really grateful to be joining you all from the cold but sunny Vancouver on the west coast of Canada this morning. I'm joining you from my bedroom, which also doubles as my home office. Like Kristen said, I have 4 young children, so the only place we can have a little bit of quiet for an hour is by locking the door to my bedroom. But I'm so grateful to be here, and I trust your patience with my strong Canadian accent over the next 45 minutes or so. This topic, the talk I've giving today, I've titled Addiction, Ethics, and the Human Person. I'm very grateful to be sharing on this subject, which is a matter interest to me just a little bit more about myself. So as Kristen said, my primary hat that I wear, so to speak, professionally is that I work clinically at St. Paul's Hospital. St. Paul's is the kind of big tertiary academic hospital in downtown Vancouver. There's a particular neighborhood in the downtown core of Vancouver that we call the downtown east side that in Canada is very famous, sort of infamous. People call it sort of ground zero for the fentanyl crisis or the overdose epidemic. And so a lot of my clinical practice has to do with addictions medicine and just the tragedies that are so commonplace to us shift after shift after shift at St. Paul's. And prior to starting practice at St. Paul's, I had my master's degree. I was interested in ethics. I was interested in roles in ethics, and I had plenty of soapboxes that I like to get up on. And when I started working at St. Paul's, we came here for a 1-year fellowship, and my wife and I, neither of us are from Vancouver. Our plan was to leave, and I started working at St. Paul's, and started encountering all the issues around addiction. And I repeatedly said to my wife, I have enough soapboxes. I'm not going to pick up this soapbox. It's too tragic. It's too challenging. And I have enough other things to do. And my wife, in her far superior wisdom and patience, would just sort of smile and nod and say, like, okay, you just wait. And after a year went by of working as a fellow at St. Paul's, we found both my own individual sense of calling, but also us as a family felt deeply called to stay and to work in Vancouver. And so I'm really proud and honored to do the work that I do on a day-to-day basis. A lot of very challenging emergency medicine, a lot of forensic medicine, a lot of mental health, and a lot of addiction-related medicine and overdoses. And this is an area, before we sort of dive into my outline for today, I just want to talk about briefly in terms of why talking about addiction. I think one thing that I've learned from my work, both my clinical work, but also sort of my professional work as an ethicist, is when we talk about issues like this, we all come to the table with our minds. And I think all of us would agree and be aware that this is an area that deserves the close attention of our minds because the stakes are incredibly high. But also we come to the table with skin in the game. Given how tragically common severe addictions are and the fracturing of relationships and communities that comes with severe addiction. These are issues that impact all of our communities. And I suspect all of us in our own network of family and friends and relationships, these are issues that impact most, if not all, of our network of personal relationships. These are areas that are important to me personally as a matter of my mind, and also deeply as a matter of my heart and my guts. And these are two pictures that are significant to me in this respect. The one on the left is one of many dozens of graphics I could have put up to illustrate to us today how the stakes of this issue are so incredibly high. This is a graph taken from the United States that shows the drug-involved overdose deaths. And in 2021, more than 106,000 people died of overdoses in the United States. And each of those 106,699 data points is a person, the loss of a human person who is themselves beautiful and irreplaceable. Each of those 106,699, the fracturing, the breaking of a network of relationships and mutual dependencies. The brokenness, the tragedy in individuals and communities should not be reduced to the clinical language of morbidity and mortality. We can and we should feel the utter weight of tragedy. But at the same time, we should be attentive to the way that those are not just tragic statistics, that addiction is something that involves persons. And as is so often true on a variety of these issues, the beginning of speaking productively means closely being attentive to persons, especially to persons who are very different from ourselves. And this is part of the reason that, my initial refusal to take this up as a matter of interest was slowly won over. It was won over because of my guts from my day-to-day encounters with persons with severe addictions, and not just seeing the way that there was such tragedy there, but seeing the way that each of these persons is wonderful and unique and deserving of respect and even reverence, learning to look across at them as a neighbor, and even to look up at them for all of the ways that their lives present things that I can and should learn from. And the first story I always want to tell, as long as I think and write and speak about this issue, the first story that I always want to tell is a story that took place in my first couple of months of practice. And those of you who are practicing physicians will maybe relate to, especially in, settings where there's, critical care, those things in your first few months, you're nervous, you're just trying to, figure out how to swim with all that responsibility. And I was sitting at my desk in the Emerge talking to a medical student, and my local phone rang, and it was the triage nurse. And she said, I just triaged this guy. He's got a violence flag on his chart. He was really disorganized. He couldn't even really tell me what he wanted, and he's making all the other patients nervous. So can you go see him right away before anything scary happens? So I opened this gentleman's chart to review his past medical history, and he had a very well-documented history of addiction to amphetamines. He had a very well-documented forensic history and had been in and out of jail for many years as per his chart. And in the past couple of months, I noticed that he'd had several consultations from the addictions physicians at St. Paul's, and repeatedly, using our language of stages of change and those kinds of things. But the messaging from their notes was, this gentleman is really trying. He's articulating that he's really trying to make efforts with respect to his addiction. So with that kind of chart review in mind, I left the security of my desk and I went out into our crazy waiting room at St. Paul's. And our waiting room for such a big hospital is quite small, and it's got maybe 30 chairs, and usually every chair is full of a person with people sort of standing around the walls as well. But on this day when I went outside, there was one individual who I, without having to check his armband, knew was the patient in question, was sitting right in the middle of the waiting room, and there was this large buffer of empty chairs around him, and all the other patients were sort of crowded around the walls. And it was easy to see on first glance why the other patients were made a bit nervous by this gentleman. He was sitting in a chair, and his hands were clenching and pulling his hair, and he was mumbling and rocking back and forth, and sometimes making jerking movements with his arms, and his feet were pounding the floor, and he was visibly sweaty, and he had bugs on his clothes, and he smelled very strong. And it was easy to understand why the other patients in our waiting room were nervous to get close to him. And I went and I sat beside him, and I put my hand on his shoulder to let him know that I was there. And I leaned forward to introduce myself to him. And as I did that, I just paused for sort of that split second. And I'm grateful to say that before I opened my big mouth, I heard a little snippet of what he was saying as he was rocking back and forth and talking to himself in a way that seemed to the other patients to be crazy. And I realized in that moment that he was praying, that he was saying to himself, or he was saying over and over and over again, he was saying, "Dear Jesus, I don't need meth. I don't need meth. I don't need meth. Dear Jesus, I don't need meth." And I then intervened and introduced myself and tried to figure out how best I could help him. But I was so struck in saying goodbye to him at the end of our encounter that day that I wished I had asked him to pray for me. And I wished I had asked him to pray for my own selfish and self-concerned and prideful soul. Because if there is a ladder of holiness, if there is a ladder of good people and bad people, and by the way, I don't think there is, but if there was, I would certainly want to say that he's above me. That there are things about perseverance and intensity and focus of prayer, but he knows that I don't. And that isn't to lessen the tragedies in his life in any way, but it is to make us more attentive to them, that the loss and the suffering of his life are significant because he is so significant, because of his capacity as an agent, as a person. And so addiction is important. It deserves the attention of our mind, and it deserves the deep attention of our guts and our hearts, because persons are important, because persons matter. And even persons who are very different than us, and persons with severe addictions often appear different from us by the things they do that seem superficially quite bizarre. We must cultivate the gaze to look across and even up at them. So that's a very lengthy preamble, but hopefully just sets the table in terms of both my mind and my guts and what brings me to this talk today. I want to tell you that I don't have any professional disclosures or conflicts of interest. No one is paying me a large pot of money, although if you're aware of any large pots of money, I'm always interested in funding. My only personal disclosure is an apology that I have never been to the great state of Michigan. So one interesting piece of trivia about me is that I've actually been to a large majority of the states in the United States. And the reason for that is that my parents owned a very janky old motorhome like the one pictured here when I was growing up. And every summer, my mom would tell my dad he had to take a month off work, and they would load all 5 of their kids up in the motorhome and ask, which direction do you want to drive this summer? And so as a result, I've been in most places in the North American continent, but tragically, I've never been to Michigan. So I'm grateful again to join you virtually and hope to come visit in person soon. Today, I want to again talk about addiction with some overlap of anthropology, talking about what a human person is, and also some overlap into some of the ethical debates around addiction, addiction's care. To do that, I want to just set the table by telling you one more story, just presenting to you a scenario. This scenario has some features that are dramatic in some ways, but I want us to see and to soberly see how this scenario is a very common kind of scenario. This kind of thing happens in my hospital every hour of the day. I see patients in this kind of situation every single shift. And these kinds of situations are happening in our communities all over the world today. And I want us to see this scenario, therefore, as in a sense, paradigmatic and in a sense very common, that we could all recognize as an example of what addiction is. And then secondly, I want to say that if we want to care for persons like the person in this scenario, we have to be attentive to the question, what's going on in the story? What is addiction? We're going to compare and contrast the sort of polarized addiction models that dominate the scene of the popular conversation, of the academic conversation, and certainly the political conversation around addiction, to try to reveal the need for a more nuanced model. And in our limited time today, I'm just going to try to point to a couple of data points that might be helpful in developing and sustaining a more nuanced model. So here's my paradigmatic situation. So I was working at St. Paul's early one morning, and at St. Paul's, we have an area of our emerge is divided into 2 sides. We have what's called acute. We have another side that's called fast track, and we all chuckle at the name. All the docs chuckle at the name fast track because on paper it's supposed to be for small problems that you can fix in one face-to-face encounter in 15 minutes or less. And I don't think I have ever seen a case in fast track that satisfies that criterion. So this is a good example of that. One morning I was working in fast track and I saw a gentleman who came in with an infection, a cellulitis to his leg. This is a very common thing we see in fast track, especially in patients who use IV substances or IV drugs. So this gentleman had a long history of IV drug use. He had an infection to his leg because he'd missed a vein. And he came in, he knew our system very well. So I had an initial, more straightforward discussion with him, talking about antibiotic planning and wound care planning and follow-up and all those kinds of things. And when we were finished that part of the encounter, I did something that I always try to do, even in our crazy emergency department, and that is to ask a kind of an open-ended question to offer other kinds of help as I can to the patient. So I sat down beside the patient to communicate with my body that I wasn't in a rush, even though I kind of was, because it's St. Paul's emergency department. And I put my hand on his leg to try to communicate with my body that I cared about him and that I was close to him and was present to him in this time of pain and discomfort. And I asked him an open-ended question, something like, is there any other way I can help you today? Or is there any other thing that I can do for you today? And when I asked him that, he sort of looked a bit nervous, which usually reveals that there is something else he's interested in saying. And after sort of fidgeting for a few seconds, he said, yeah, actually, do you mind if you refer me up to RAC? And as this picture on the slide shows, RAC is our Rapid Access Addictions clinic at St. Paul's Hospital. And I said, yeah, I'd love to do that. Do you mind just telling me a bit more about why you want to go to RAC, or if there's any other things I can do for you? And this is the story that he told me. He said, I've been shooting down for about 10 years. And I don't know about your settings in Vancouver. When people use the word down, they mean opioids of some kind, usually fentanyl. So what he meant is I've been injecting fentanyl and similar opioids that he'd been buying on the street for a long time. And he said, for a lot of years, I was homeless in the downtown east side. But he said, about a year ago, my mom got very sick. And my parents somehow contacted me because my mom was dying. And in that time, he moved home and rebuilt his relationship with his mother and his father, who lived in downtown Vancouver as well. And he said that in those last weeks of his mother's life, he kind of stopped using drugs, and he experienced some withdrawal, but even outside of a medical context, he just kind of stopped using because there was so much going on. And he said that in those last weeks of his mother's life, he experienced real, even amidst the tragedy, real joy in rebuilding his relationship with his parents. And he told me the language that he used was that of a deathbed request. He said, when I was holding my mother's hand when she was on her deathbed, she asked me to promise her that I would never use again, that I would never use down again. And he had promised his mother, and then she had died. And then he had stayed home and worked on his relationship with his father and joined the 12-step program. And all that had lasted for about 10 months. And he told me that in that 10 months, he had experienced again real joy and purpose in mutual relationships that he'd never experienced before in his life. But then something happened and he started using again. And he told me on that day in St. Paul's, he said he didn't even remember why. He said, I can't even remember why. I just couldn't help it. And he had snuck around behind his dad's back for 6 weeks or something like that. And then the day that I saw him at St. Paul's, his infected leg had given him away. And his dad packed him a bag and drove him to St. Paul's. And they sat out on the street outside of my emergency department in his dad's car. And his dad said to him, when they release you from hospital, you have to find a new place to stay. You can't come home anymore because you broke this promise to your mom. And I sat there in the quiet devastation of that moment with this young man, younger than me. And he shared with me feelings of anger with himself, shame, a feeling of powerlessness and helplessness. And he said to me, he said, Doctor, I hate down. I hate it. But I can't stop. Why can't I stop? I want us to first see that this situation, in some senses, has some dramatic features, but is tragically incredibly common. Incredibly common. I want to also say, I believe very strongly that part of caring for this patient is being able to answer his question. I hate down, but I can't stop. Why can't I stop? To answer that question, we must be able to answer the question, what is addiction? I think this is a situation that almost anyone would recognize as an example of a phenomenon, a recognizable phenomenon called addiction. And because of the urgency of this issue involving persons, we should be attentive to the issue with both our mind and our guts. And in order to help him, we have to be able to answer that question, why can't I stop? So this is a core question for me that I believe we need more nuanced answers to, and this question is, what is addiction? Just a brief semantic break. I'm going to go over this quickly in the interest of time, but if you want to talk more in the questions or send me an email, I'm happy to explain this a bit more. Semantics is an area of philosophy that's very unpopular in our time. You know, when you're debating with someone and they say that's just semantics, you know, they're kind of done talking to you. But semantics is really important. You know, trying to choose the words trying to select words well to convey meaning is very important. So I'm choosing this core question, what is addiction? I think when we're looking for language in ethics to describe phenomena that happens to persons, I think we should seek language that is both precise and also non-derogatory, that is respectful of persons and not dehumanizing or depersonalizing to them. So in satisfying those two criteria, for me, addiction is a reasonably precise word that both in the lay conversation and the academic conversation is a recognizable phenomenon. And there's nothing about this term that is inherently demeaning or derogatory to persons. Here are some examples of some terms that I don't use. So one example that's very common in my environment was people want to say, not use the term addiction, but just say a person who uses substances. And the attempt behind this word is to be more respectful, to sort of say, well, everyone uses substances. We just use substances in different kind of ways. I want to respect the motivation for that by saying it's an attempt to point to the things we have in common with persons with addiction. But I think this phrase has a lack of precision. I use a substance when I breathe, or when I put gas in my car, or when I put milk in my cereal. So yes, everyone uses substances, but addiction is a particular kind of way to use a substance, and we should seek more precise language in this. The second phrase here is substance use disorder. I don't really have any beef with this phrase, but for me, addiction is a more overarching term that can include phenomena that I think we would all recognize as overlapping, such as addiction to gambling or pornography, that doesn't specifically denote a substance. So this language in the DSM of a substance use disorder, I think can be helpful language, and it's language that I use sometimes, but I still think the question, what is addiction, is sort of more foundational or fundamental. Thirdly, recreational drug use. Recreational drug use, as I'm sure most of you know, is a real thing, but it is a different thing than addiction. And so it can be potentially very inattentive to persons to say this is all recreational drug use. If you ask lots of my patients at St. Paul's who have severe addictions, including this gentleman who says he hates down, to say that that's recreational, I think is not paying close enough attention to what's really going on there. So again, recreational drug use is a real thing, but it is a different thing than the phenomenon we call addiction. Finally, I myself don't use the term addict, and you'll see in the following that when I quote other people or researchers, if they use the term addict, I keep it, but myself, I try to avoid using this phrase wherever possible. For me, it's really important to cultivate language that cultivates the gaze to see always the other as a person or as a neighbor. And so when I describe them in a noun, I always want to use like person. And so I don't say that addict, I say that person who has an addiction or that person with an addiction. That might seem like a semantic splitting hairs. For me, it's quite significant. And similarly, by the way, I try also not to say that diabetic in bed 14 or that vasculopath over there or something like that. So in this and all kinds of other issues, to try to cultivate language that shapes our perspective towards the other, that sees they are not defined by particular behaviors or activities, but they're primarily defined by being a person who's deserving of respect and even reverence. So now we're going to take a bit of time to dive into these different models of addiction. So what is addiction is our core question. We're going to consider what are broadly called choice models and disease models of addiction. We're going to evaluate them by asking, do they have explanatory and predictive power? Are they logically consistent? And are they adequately respectful of persons? To frame this conversation for us a bit, I think one of the oldest and most important questions within philosophy is the question of how do we explain human behavior? So human behavior is very difficult to explain. And I think all of us would identify with this personally. Sometimes our own behavior is hard to understand even in ourselves. And particularly phenomena like addiction can seem confusing and paradoxical to explain. And this is, again, very well captured in this thing the patient says to me, I hate down, I hate it, I don't want to do it, but I keep doing it. And for those of you who share my faith tradition, I often think this sounds like something that St. Paul says in Romans chapter 8, when he says, the things I want to do, I don't do, but the things I hate, I do. And this internal self-reflection, what does it mean that the things that I most deeply desire, I find myself acting contrary to them? So this is not just a narrow question with respect to addiction. This keys onto a broader question: how do we explain human behavior? And some of the greatest philosophers of history spent a lot of time trying to develop language categories to explain the relation, for example, of action to will. What is the relation of the human will to the human action? And at the extremes of this question are two systems of explanation that are called voluntarist systems and determinist systems. So voluntarist systems, just to review, quickly says the will is the only thing that matters. So if you want to explain a human behavior, the only thing that you really need to know is what they will, what they want. If you want to know why someone does something, they might say, oh, I do what I don't want to do. But really, what they do reveals their will, and that's all you need to know to explain their behavior. And voluntarism is a system of thought that is very present in our contemporary views of bioethics, especially those that are very heavily autonomy laden. If you want to explain the value of someone, you just need to know what they will or what they want. But voluntarism and voluntarist systems are very old and stretch back at least to ancient Greece. At the other end of this system, at the other end of this extreme, the other pole is called determinism. And determinism says the human will is an illusion that doesn't matter. It doesn't have explanatory power. If you want to know why someone does something, if you want to explain an action or a behavior, you might superficially think that the individual's will, what they want, has explanatory power, but really it doesn't. There's some other factor that is driving their action. And in our time, there are certain kinds of determinisms. You might call them like neurobiological determinisms. It says free will is an illusion. that is granted through some evolutionary process, but really doesn't explain our behavior at all. But determinism is, like voluntarism, actually a very old system of thought. The Stoics, for example, Stoicism is very trendy nowadays for a variety of reasons. But the Stoics, amongst other schools of Greek thought, would say, we think we have a free will, but actually what happens in our lives is largely written by the gods or the fates or whatever. So if you've read Oedipus Rex, for example, Oedipus is fated to do certain kinds of things. And part of the tragedy is that he thinks he has a free will, but actually he cannot alter his fate. That's a determinist view of the relation between human behavior or what happens to human beings in the will. In our time, each of these extremes of explanatory model corresponds to a particular model of addiction. Each of these poles, each of these extremes, and as we'll see, there are other positions, there are more nuanced middle positions, but each of these extremes or poles corresponds to a particular way of seeing the particular human phenomena of addiction. So corresponding to voluntarism, the will is the only thing that matters, is what's called choice models of addiction. And corresponding to determinism, the will is an illusion that doesn't have explanatory power, is what we call disease or disease models of addiction. But just to flag my thesis for the coming 10 minutes or so, I want to first of all give a little advertisement for this book by Kent Dunnington, which is a wonderful book if you want to read something about addiction. And I'm following him to some degree in my arguments here over the next little bit. And he says in this book, he says, should addiction be understood as a disease or a choice? This is the most long-standing and contentious question in addiction research, and people love to fight about this question. This question, however, rests on a false dichotomy. The false dichotomy arises from a failure or an inability to conceive of a genuine space between compulsion and choice, between determinism and voluntarism. So quickly, the choice models of addiction, and some of these are called by slightly different names, liberal models of addiction, autonomy models of addiction, but broadly speaking, these fall under the umbrella of the choice models of addiction. These models deny that addiction is any special category of human behavior at all. In this view, what people do, how people act, is reflective of what they want. And people want different things. You might moralize that, or you might not see that in moral categories. But ultimately, what people do is a reflection of what they want. They might say they want something else, but what they do reflects what they want. That's true for everyone. And so someone might say that he loves his mom and his loyalty to the promise he made to his mom more than he loves fentanyl. But really, his actions reveal what his real values are. And so in this sense, addiction is not a special category of human behavior at all, but addiction is just a response to particular appetites or desires. And everyone has different appetites or desires. Different people's appetites might be inscrutable. It might be hard to understand why someone loves fentanyl so much when the consequences are so dire. But really, that is just that person's particular will or their appetite. Now, this might sound like a, I was going to say that this view is alive and well in our own time. So certainly in the circles where I work, this view is very much anathema in Vancouver in 2024. And a lot of people in medical context would be very suspicious of this view, I think, in many ways for good reasons. But this view is still alive and well. And one good example of this is the work of Julian Savulescu, who is one of the most prominent bioethicists in the world today. He's a professor at Oxford, and he wrote a paper with Brian Foddy where he advocated for a view that he called the liberal view, which is essentially a kind of a choice model. And he said the liberal view contains three claims. First, we don't know whether an addict values anything more than the satisfaction of his desires. Second, we don't know whether they're autonomous or not. Thirdly, most importantly, addictive desires are just strong, regular, appetitive desires. So if you want to explain addiction, you don't need to look at the brain or at early life experiences, or you don't need to look at any more complicated view of human behavior. All you have to know is that everyone has appetites, people follow their appetites. Addictive desires are not different, they're just regular human appetitive desires. What are the problems with the choice model? Well, I expect that many of us hearing some of these things, immediately stories or anecdotes would pop into our mind of cases of addiction that seem to not follow this rule. So I have a patient who comes in frequently to St. Paul's who her first time using fentanyl was her mother injecting her at age 12 as a reward, in quotes there, for good behavior. And she was severely dependent by the time she was 13 because of her mother injecting her at home in response to various things. And we have many patients who come to St. Paul's who are forcibly injected as a part of human trafficking. And we know in our time that more than 70% of people with opioid use disorders receive their first opioids from a doctor. And so to simply say, people have different desires, people who are addicted to opioids just want opioids more than anything else, is missing some key pieces of the puzzle. And as Dunnington says, by insisting on the language of voluntarism, the choice model reduces addiction to mere weakness of will. In its more cynical mode, the choice model characterizes attributions of addiction as a perverse psychological form of rationalization and excuse. The assumption is it's just excuses standing between an addict and recovery. The overwhelming report of persons with serious addictions flies in the face of this attempt to reduce addictive behavior to a type of weakness. This is functionally why the disease model of addiction has been helpful to many persons with addictions. It resonates with the person's experience as something other than everyday struggles of will, thus removing the stigma that accompanies the choice concept of addiction, according to which addiction is simply willful misconduct. One thing that's important to me in an attempt to be a good scholar is to always have charitable views of different models, to not just to say what's wrong or what's lacking or what requires nuance, but to say, what can we learn from the choice model? And so I work in a context where, anyone who said that they were in favor of the choice model would be very strongly disagreed with. And it's very common to say the choice model is terrible and judgmental. But I think we should be more patient than that with our minds. We should ask what's right about this model, or at least how can we jump off this model to learn something? So two quick reflections on this. First of all, the point about agency. So if you ask Savulescu, for example, I don't know Savulescu, but from reading a bunch of his work, I would guess that if you asked him why he defends his choice model so vehemently, it would have to do with a certain commitment around autonomy and agency. He famously says in one of his works that in the disease model, a person can't choose to stop. The disease model can't make sense of a willful choice to stop. And he would want to defend at all costs the assertion that even a person with an addiction remains an active moral agent. And I think we have something to learn from that. And I have a story that I'm just going to skip over here that references this ball cap and this quote. But essentially, I saw a patient at St. Paul's who had been in and through our addiction system for a long time. And I had a conversation with her where I told her, you can stop. And that she came back later and she said to me that you were the first person who told me I could stop. You were the first person who told me I could, that I was an agent. And she had so many encounters with our addiction system and program, and dozens of encounters. No one ever told her that she was an agent, that she remained an agent despite the severity of her addiction. Secondly, I do think that the choice model can, if we give it a charitable read, make us attentive to the question of why. The disease model says why someone uses drugs is because they have a permanent, irrelatable brain disease and renders their choices or their behaviors outside the realm of something we could identify with or ask why. And the choice model, if we give it a charitable read, can prompt us towards a humanizing gaze towards the patient that asks why. What are they seeking? What are they looking for? Might there be real goods that they're seeking through this destructive pattern of addiction? Secondly, the disease model of addiction. This at the other end of the spectrum is a determinist model. So I took my daughter to a birthday party at a rec center here in Vancouver. And while she was playing in the gym with the other 5-year-olds, I was standing outside on my phone because I was a dad. I didn't know what to do at this birthday party. So I was looking at the bulletin board and I saw this poster that said, addiction is a medical condition, not a choice. Stop the stigma. And it told me to go to stopoverdosebc.ca, which I did. And right at the top there in my mobile view, it said, addiction is a health condition. It's the result of external factors, not personal choices. So this is simply put a kind of determinism. This young gentleman who I talked about in the first story, he engaged in a variety of behaviors that seemed to be acts of the will. He stole stuff from his dad and sold it to make money. He texted a particular person and arranged to meet that person in a particular place. He purchased something from that person, went home, prepared that substance in ways that were elaborate and even ritualized and injected them. At the most superficial level, all of those things appear to be acts of the will. But what Stop Overdose BC is telling us is that is not an act of the will, that the superficial analysis that relates to his will is an illusion. These behaviors in the addiction are driven by something else, not by the will. And NIDA phrases it like this: drug addiction is a brain disease because the use of drugs leads to changes in structure and function of the brain. So the disease model says, as the other pull from the choice model, that addiction is an issue, a phenomenon that happens to persons where if you want to explain it, the will is not at all relevant. What are some problems with the disease model? Well, there's lots more we could say about this, but some quick things to summarize briefly here. First of all, one interesting thing, especially in the setting that I work in, is the direct conflict between theories of ethics that are very heavily autonomy-based and accepting a disease view model of addiction. So many people in my setting want to say persons with addictions, they have rights, they're autonomous agents, they have rights to certain kinds of things with respect to the substances that they use. But it's very difficult to say that and also to say that they don't have any will when they use, they're not making a choice. You could say you have an autonomous choice. You could have a non-autonomous choice. It'd be difficult to understand how you could have an autonomous non-choice. So if something is not a choice, it's difficult to understand how that is autonomous. And I'm not someone who's that invested in the language of autonomy, but for me, I'm very invested in the language of agency. And so the disease model has trouble retaining a high view of a person as an agent. It sees them as perhaps at best a passive victim. But in seeing their choices as not related to the will and pathological, it reduces or even nullifies their agency. There's several other problems with the disease model, and Dunnington goes through these in more detail than me, but there's a hole in NIDA's quote there, in that something that changes brain structure and function does not necessarily produce involuntary behavior. So we know from MRIs that concert violinists, they have permanent changes to brain structure and function that interestingly in some ways are similar to the permanent changes of persons with severe addiction. No one would want to say that that concert violinist playing their violin is involuntary. We certainly wouldn't want to say that it's pathological. So as a logical point, it is not necessarily true that something that changes brain structure and neurochemistry necessarily produces involuntary or even pathological behavior. The disease model also has many problems in explaining the phenomenon of recovery. And so again, as Savulescu says, in the disease model, you can't readily explain how someone would choose to stop. And so this young man who I saw at St. Paul's, he said that he stopped using because he made a promise to his dying mother. And all the disease model could say is that he had idiopathic, spontaneous, temporary remission of disease. And for me, that's clearly missing something in terms of explanatory power, but it's also, for me, deeply disrespectful to the person, to the way that his particular story, his particular relationships, his love and his loyalty for his mother are key factors in explaining and interpreting his addiction. And this, I'm not the first one to draw some of these criticisms. This is a quote by some neuroscientists who are really engaged in these issues. So again, these are neuroscientists, and they say recovery is the project of the heart and mind. The person, not his or her autonomous brain, is the agency of recovery. The most effective interventions aim not at the brain, but at the person. It's the minds of person with addiction that contain the stories of how addiction happened, which people continue to use drugs, and if they decide to stop, how they manage to do so. This deeply personal history can't be understood exclusively by inspecting neural circuitry. Secondly, this is a quote from Gabor Mate, who some of you may have heard of. He's a physician that does a whole bunch of work and writing around addiction. I disagree with him on a whole bunch of fronts, but I respect him as someone who really worked closely and really sought to care deeply for his patients who had severe addictions. And he is sympathetic to the disease model, but for him, one of the real barriers is that in his experience, persons with severe addictions themselves don't buy it. And he says we cannot reduce human beings to their neurochemistry. Even if we could, people's physiology doesn't develop separately from their events and emotions. Persons with addictions themselves sense this. Easy as it would be to pin their responsibility on a chemical phenomenon, few of them do so. Few of them accept a narrow medical model of illness. And this certainly accords to my own experience working in Vancouver's downtown east side. What can we learn from the disease model, again, trying to put on our good scholar hats and have a charitable view of this model? Firstly, I think many people who I know who are dogmatically committed to the disease model are committed that way because of compassionate motivation. They want to say good, humanizing, non-judgmental things about persons with addictions. And my response to them is to say yes. And that motivation is deeply good. And those people who are very adherent to the disease model are not enemies, they're friends. But it's helpful, to build relationships and try together to nuance those models. And in Vancouver, you see people, outreach workers all over the place in downtown wearing shirts that say things like drug users are nice people. They're desperate to say humanizing, respectful things that emphasize our commonality with those with severe addictions. And I want to say to that, yes, that motivation is good. But there's a certain irony here, and perhaps this is a sad irony, that a model that starts with that motivation ends up saying that persons with addictions have a permanent brain disease. Something that starts with the motivation to say they're not so different from us ends up saying they are completely different from us. Their behaviors are irrelatable, pathological by definition. So we should try to nuance the model, but we should respect the ways that the development of this model has a lot to do with and comes from the desire to say compassionate, humanizing, respectful things about persons. One really important thing about the disease model that I want to just jump off in terms of our charitable view is to pick up this question of culpability. So in its more cynical modes, the choice model says persons with addictions are choosing their addiction, therefore they're culpable, therefore we shouldn't help them, or therefore at least our responsibility to help them is less. And many people who adhere to the disease model want desperately to help. But often they accept this same premise that help should be proportional to culpability. And so then in order to defend their desire to help, they have to construct a model that says the person is not culpable at all. And the disease model can try to do some of that work. And I would want to say, and I'll sort of draw an analogy here in a second, that we should cheerfully try to ignore or transcend and leave behind this whole help is proportional to culpability premise. We should be motivated to help persons with addiction because they are persons. We should be cheerfully agnostic about their degree of culpability. Some patients, as I've said, have tragic, horrible stories where it would be really cynical and judgmental to feel that they were culpable in any significant way. But many patients would themselves tell you that their own choices play a role and they're culpable to some degree. It is not our job, our stance, to look and say, you are this percent culpable and you are that percent culpable. It is our job to help. And we should be motivated to help, not because they're not culpable or because they're not in any way responsible, but because they are persons. And as persons, they compel our respect and even reverence. And here, I think there are helpful points of analogy to draw with various diseases. So for example, I see the patient in the emergency department who has a heart attack. Maybe their heart attack is to some degree driven by factors that relate to their will, the smoking and dietary habits and exercise and those kinds of things. Maybe their heart attack is contributed to by things that don't implicate their will, their family history or those kinds of things. It is not my job as a physician to say, you are 20% responsible for your heart attack and you are 80% responsible for your heart attack. That would both be a ridiculous thing to do because those things are impossible to unwind, but it would also be deeply undercutting the trust between me and my patient. It is my job to treat their heart attack. And I should be attentive to the causes to promote their future health. It is good for me to ask about smoking so I can tell them to stop smoking, but not that their smoking impacts how much I should help them. Similarly, we can and should be cheerfully agnostic about the culpability question in addiction. We should be attentive, as Sattel and Lilienfeld have said, to the factors that cause addiction to help promote recovery, but not as part of a culpability judgment. And so we should agree with the disease model's intent to say we should help. But in that sense, the disease model doesn't go far enough in distancing itself from the cynical modes of the choice model. It still accepts this premise that help should be proportional to culpability. And we should say care is not attached to culpability, but is attached to what a person is. So this is a premise that I've been working with and I'm nuancing and building out. The choice model suggests that people with addiction are bad, either immoral or incompetent actors. The disease model correctly suggests that such a view is inadequate and dehumanizing, but suggests an alternative where persons with addiction are not actors at all. Despite the good intentions of most people who hold this latter view, it therefore also risks dehumanization by implying that people with addiction lack will and volitional freedom. It sees persons as passive victims rather than as admirable, deeply resilient persons. So what we need to do is to find ways to move beyond this simple sort of polarized dichotomy and work towards mediating categories. So how can we conceive? I know I'm just talking so long. I'm sorry, Christina. How can we conceive of a middle space? And I just want to go over a couple of things very briefly here as we wrap up. There's a lot I could say here, and I think Thomas Aquinas is a really helpful conversation partner here that I'm not going to mention. I'm going to pick up a system of Aristotle here just quickly. So Aristotle in the Nicomachean Ethics describes 5 different categories of behavior, 4 of which he sees as human behaviors, and the other one he sees as sort of morbid or pathological. All of these, again, relate to the relationship of the reason, the appetite, or the will, and the human action. So for Aristotle, first you have the virtuous actor. The virtuous actor is capable of rationally judging what is right from wrong. And the virtuous person has been formed so their appetites, their desires are in line with their reason, and so they do what is right. And this virtuous is the ideal. This person has total authenticity or integrity, you might say. Then Aristotle describes what he calls the continent actor. And I know medical people are always like continent, but he's not talking about urine or anything here. This is a philosophical category. So for Aristotle, he describes the continent actor. The continent actor is rationally able to judge right for wrong, but they have some appetite, some bodily desire that tempts them to do what is wrong. And the continent actor is able to overcome that through their reason and still do what is right. In contrast, the incontinent actor is a human agent who's able to rationally judge right from wrong, but something tempts them, some bodily appetite or factor of the will, tempts them to do something else. And in that moment, they do the wrong thing that they know in their reason to be wrong, but that's driven by some appetite. Finally, there's the vicious actor. And the vicious actor is capable of judging right from wrong, but does not correctly judge right from wrong. And so they do the wrong thing because they incorrectly judge what is right. And this does not, in brackets, is important. The vicious person corresponding to vice can rationally judge right from wrong, but in this instance, they don't. Finally, there's what Aristotle called the morbid actor. And this morbid actor, for reasons of what he would call insanity, is unable to judge right from wrong. They have a brain condition that says they cannot know what is in keeping with the good. And so they cannot judge right from wrong. And this, for Aristotle, is not in keeping with what he would call human action. This is driven by morbidity. The choice model says that persons with addictions are essentially vicious actors. They could judge what is right from wrong, but they don't. The disease model says that persons with addictions are morbid action, that they're morbid actors, that their addiction lies completely outside of the realm of human behavior, that their will is not involved at all, that they are incapable of exerting their will towards the good. And I think a much more helpful beginning mediating category is the category of incontinence. And again, we could maybe nuance this language or change the title again, because incontinence sounds funny to us. But the incontinent actor is someone who remains an agent. They are able to aspire to the good. They say, I hate down, I hate it. They know deeply that using fentanyl every day is not in keeping with the good and having a relationship with your father. They know that. But addiction is some factor, and to nuance a little bit, Aristotle might call this impetuous incontinence, some factor that short circuits or makes haywire the ability to connect those highest desires to individual action. And this, I think, makes sense of the things we would want to learn from the choice model and of the things we would want to learn from the disease model. There's a lot of further nuancing we could do, but that's just one sort of data point that I think is important in a very ancient conversation partner who can actually help us with this very contemporary question. So some new premises that I'm working with, I want to say that unlike most diseases, addiction is a phenomenon that undermines the voluntary control of the agent without destroying or nullifying their agency. Like many diseases, addiction has multifactorial causality. The physician's task is not to judge the degree of culpability or autonomy, but to promote health. And thirdly, as we pointed to a little bit into the question of why, persons with addictions remain agents who are seeking common human goods. Addiction provides an ordering principle to their life, which is bad because it eclipses other goods. Recovery must involve displacing that bad ordering principle with less undermining ways of pursuing common moral goods. I just want to conclude here by just sharing with you two words of hopeful encouragement. So this more, explicitly relates to the sort of religious and spiritual, my own tradition. One thing that I think is really important, I experience a lot of moral outrage in my work in both thinking about addiction and how little help we as a society offer to persons with addictions, but also moral outrage at just seeing the tragedy. And one thing that's really important for me is recognizing that moral outrage is not a rage against God, but bringing that moral outrage under God and having my moral outrage in the name of God against suffering and against those who cause it. So this is just a prayer I've written for moral outrage. I'm just going to read to you. So every Sunday, someone hands me a little cube of bread. I dip it into a cup of wine. Every Sunday, someone says to me, the body of Christ broken for you, the blood of Christ shed for you. I take and eat. Then I sit, and every Sunday I pray. Body of Christ broken for those who are slumped over on orange chairs in triage hallway. Blood of Christ shed for the ones on Narcan infusions. Body of Christ broken for those with violent flags on their charts. Blood of Christ shed for the ones with fresh track marks on their arms. Body of Christ broken for those who are banned from the shelters. Blood of Christ for the ones with delusional parasitosis. Body of Christ for those who hope without hope that fentanyl will make them forget. Blood of Christ for the ones with maggots in their leg wounds. Body of Christ for those who inject with dirty needles. Blood of Christ for the malingerers. Body of Christ for those with endocarditis and septic emboli. Blood of Christ for those who cannot seem to stay on their meds. Body for those who are paranoid and hallucinating. Blood for the ones sleeping on Hastings without shoes. Body for those in precipitated withdrawal. Blood for the ones who cry like children when we change their bandages. Body for those who leave against medical advice. Blood for the ones who are certified and restrained. Body for those who were brought in after a first ever overdose. Blood for the ones who were stretchered in after their last. Body and blood, broken and shed. I don't want any victory that doesn't include them. At the cross, God damn any victory that doesn't include them. I don't want any victory that doesn't include them. And finally, a word for hope that corresponds, I think, to some of the theme of my outrage prayer. Moldman says, the joy in life's happiness motivates us to revolt against life that is destroyed and against those who destroy life. And grief over life that is destroyed is nothing over than an ardent longing for life's liberation to happiness and joy. Otherwise, we would accept innocent suffering and destroyed life as our fate and destiny. Compassion is the other side of living joy. We don't accuse God because there's suffering in the world. Rather, we protest in the name of God against suffering and those who cause it. These issues are so important, the stakes so high, because persons matter so much. And I will leave it at that because I'm such a long talker. So I skimmed over some stuff in the end there. I don't know if we have time for any questions, but thanks again.
Quentin, thanks. I mean, really, it's hard to say anything after that powerful ending. So we are friends at the end of our time together. I was just reading a poem by Wendell Berry about leavings, and he says in his poem that heaven enough for me would be this world as I know it, but redeemed of our abuse of it and one another. It just reminds me of that beautiful prayer that you shared with us. So thank you. Thank you so much, Quentin. I will see you in Vancouver, hopefully when I come back to Canada next, this fall.
That's great. I'll see you then.
Yeah, see you there. We can talk more about these topics. And again, friends, thanks so much for joining us today. We will be posting the recording of Quentin's talk on our website once we have it up. And peace to all of you today. Thank you, friends. Bye-bye.